conduct the empty can test, the patient is in standing or sitting position. The arms of the patient are elevated to 90 degrees in the scapular plane. The arms are then fully internally rotated so that the thumbs point towards the floor. The patient is then instructed to resist downward pressure applied by the examiner. A positive test is indicated by weakness and or pain of the affected arm compared to the unaffected side. The patient is in sitting or standing position so that the arms can hang relaxed along the trunk, but not quite touching it. Then both elbows are flexed to 90 degrees, and then the examiner places the palms on the dorsum of the patient's hands. The patient is asked to externally rotate both shoulders against the examiner's resistance. As infraspinatus tears are usually painless, weakness in external rotation would raise suspicion that there might be a tear in the muscle and indicates a positive test. Have the patient in sitting position with the arm abducted to 90 degrees in the scapular plane. Flex the elbow to 90 degrees and instruct the patient to perform external rotation against your resistance. A positive test results in the inability of the patient to externally rotate in this position. Okay, if you want to
have your patient standing with the dorsum of his hand against the mid-lumbar spine. Then ask your patient to lift off the hand from the back and watch for abnormal motion of the scapula, which could indicate scapular instability. If the patient is unable to do so, this indicates a lesion of the subscapularis. If the patient is able to lift off the hand from his back, you can give resistance to test for the muscle strength. Describes two different performances of the speeds test. For the first version, ask a patient to extend his elbow and fully supinate the forearm. Then the patient flexes his shoulder from 0 to 60 degrees while the examiner gives resistance. This is probably how Spencer Speed discovered the test himself, as he was experiencing pain in the shoulder when he was performing a straight leg raise test in his patients with an outstretched arm. In the second version, which is the version that is commonly used nowadays, the patient is asked to extend his elbow, fully supinates his forearm again, and brings his shoulder into 90 degrees of flexion. In this position, the patient is asked to resist downward pressure. When a patient's arm is placed in the examining position for the speeds test and downward pressure is applied, the biceps tendon acts like a suspensor cable from its insertion on the superior labrum to the arm. Increased tension in this cable, and if inflammation is present, is thought to result in pain in the shoulder. So in both cases, the test is positive if your patient reports pain in the bicipital groove where the long tendon of the biceps enters the shoulder capsule.
Conduct the test, elevate the arm to 90 degrees of flexion, and then at maximum horizontal adduction. A positive test will produce pain on top of the shoulder near the AC joint. For the apnea stretch test, the patient is going to try to bring the hands together on the back while one hand comes from above and one from below. The patient should repeat the movement with switched arms while you are going to check for differences. It is often seen that the dominant side shows more restriction than the non-dominant side. If you see a restriction, don't be fooled though that the problem necessarily lies in the glenohumeral joint, as shoulder movement also include movements of the clavicle and scapula, and many shoulder problems are caused by insufficient scapular muscle control. To conduct the test, the patient is in supine position with the sides to be examined close to the edge of the bench. The patient's shoulder is then brought into 90 degrees of abduction. The patient is instructed to voice any apprehension or fear of subluxation to the examiner during the test. Subsequently, the examiner carefully brings the shoulder into more and more external rotation and is going to look for signs of apprehension by the patient. In a positive test, the patient reports fear of luxation at greater ranges of external rotation. Biomechanically, it makes more sense to horizontally abduct the patient's arm to have the head of the humerus glide anteriorly.
To perform the drop arm sign, have your patient in standing or sitting position and bring the affected arm into 90 degrees of abduction and external rotation passively. Then tell your patient to hold this position and release your supporting hand. This test is positive for full thickness tears of the supra and infraspinatus if your patient is unable to slowly control the downward movement. Thus the name drop arm sign. Those tests, have your patient in standing position and fixate the humerus while you palpate the lateral epicondyle. Then passively pronate your patient's forearm, flex the wrist, and extend the elbow fully. This test is positive if your patient complains about sudden pain at the lateral epicondyle. To perform this test, have your patient in a standing position, fixate your patient's humerus, and palpate the medial epicondyle at the same time. Then passively supinate your patient's forearm, extend your patient's wrist, and extend the elbow fully. Okay. This test is positive if your patient complains about sudden pain at the medial epicondyle.
To test, you can have your patient in standing position. With one hand, fixate the humerus and externally rotate it. Palpate the ulnar collateral ligament just below the medial epicondyle. The other hand you can put proximal to the wrist joint. Flex the elbow to approximately 30 degrees and then apply an abduction or valgus force. A positive test will result in increased laxity and pain. To conduct the test, you can have your patient in standing position. With one hand, fixate the humerus and put it in external rotation. Palpate the radial collateral ligament. Flex the elbow to approximately 20 to 30 degrees and then apply an adduction or varus force. Usually you will find a tense ligament, though if you experience increased laxity, a change in range of motion, pain, or a soft end feel, this indicates an injury to the ligament. Okay,
to perform the test, tap over the carpal tunnel at the wrist. McGee suggests to tap along the whole distribution of the median nerve, from the index finger towards the elbow. The test is positive for carpal tunnel syndrome if tingling or paresthesia is felt in the thumb, index finger, middle finger, and lateral half of the ring finger, which is the distribution of the median nerve. To perform the valence test, ask your patient to flex his wrists maximally and hold the dorsal side of his hands together for 1 minute. The test is positive if the patient experiences tingling in the thumb, index finger, middle finger, and the lateral half of the ring finger, which indicates carpal tunnel syndrome by pressure on the median nerve.
Scaphoid bone is one of the small carpal bones in the wrist. It is the most common wrist bone fracture in athletes, often caused by falling onto an outstretched arm. To test for a fractured scaphoid, the therapist will palpate or press down over the scaphoid bone into the area of the wrist known as the anatomical snuff box. If this is painful, then a fractured scaphoid should be suspected.
To test, have your patient in supine lying position. Normally, you would start by assessing the unaffected leg first. Then, flex your patient's leg at the hip joint whilst keeping the knee in a fully extended position, and ask your patient to inform you once symptoms occur. Normally, you would expect radicular symptoms to occur in the range between 35 to 70 degrees of hip flexion. If pain is elicited past this range, this pain is mostly coming from the lumbar spine or the sacroiliac joint. To further assess the neurological tissue, perform a straight leg raise test until symptoms occur. move out of the painful range, and then either dorsiflex the ankle, which is referred to as the Bragas sign, or ask your patient to maximally flex the neck, which is referred to as the Neri sign. If pain is elicited during any of those two maneuvers, it indicates stretch of the dura mater or a lesion within the spinal cord, which could be caused by disc herniations or tumor.
This test, have your patient in supine-lying position with the tested knee fully flexed. Then, rotate the tibia medially and bring the knee into extension. You want to repeat this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion and laterally rotate the tibia. The anterior half of the meniscus is not as easily tested with the McMurray test because the pressure on the meniscus is not as high. This test is considered positive if your patient experiences clicking, locking, or pain in the knee. To perform the anterior draw test, bring your patient's hip into 45 and your patient's knee into 90 degrees of flexion. You can fixate this position by gently sitting on the foot of your patient. Then palpate the joint line with your thumbs and try to move the tibia anteriorly in an explosive movement. This test is positive if the tibia translates anteriorly more than 6 millimeters or if you experience a soft and mushy end feel. This was our video. To perform the posterior draw test, have your patient in supine-lying position and ask your patient to flex his hip to 45 and his knee to 90 degrees. You can fixate this position by slightly sitting on the foot of your patient. Then palpate the joint line and push the tibia posteriorly in an explosive movement. This test is positive if the tibia translates posteriorly more than 6 millimeters or if you experience a soft and mushy end feel. Perform this test, have your patient in supine-lying position and bring your patient's test leg into 30 degrees of flexion. Fixate the femur with your outer hand, bring the tibia into slight external rotation, and then try to translate the tibia anteriorly. This test is positive if you experience a soft or mushy end feel or if the anterior translation of the tibia in the injured leg is at least 3 millimeters greater compared to the uninjured leg. Please keep in mind that your test results in a chronic situation will always be more valid than in an acute situation. The reason for this is that swelling and muscle spasm in an acute situation will have a negative influence on your test results.
Test the patient in supine-lying position with the legs fully extended. Now, with your patient in supine position, instruct him to relax as much as possible during the test. With one hand, grab onto the lower leg just above the ankle joint, and the other hand is used to fixate the femur. Then, slightly externally rotate the tibia and perform passive abduction in the knee joint, and thus putting stress on the medial collateral ligament. You are looking for excessive gapping on the medial side and the reproduction of pain. Consequently, perform the same test with the knee in 20 to 30 degrees of flexion. Again, you're looking for excessive gapping on the medial side and the reproduction of pain. Take a look at this table, which lists all of the structures you would assess with the valgus stress test of your patient in supine-lying position with the legs fully extended. To perform the test, instruct your patient to relax as much as possible. Grab onto the lower leg with one hand just above the ankle joint and fixate with the other hand on the medial side of the femur. Apply lateral rotation in the knee joint and perform passive adduction in the knee joints to put stress on the lateral collateral ligament. Consequently, perform the same test, but now with the knee in 20 to 30 degrees of flexion. When conducting the test, you're looking for excessive gapping on the lateral side of the knee joint, as well as pain reproduction. To interpret the outcomes of the various stress test, have your patient in supine lying position with a fully extended leg. Then, stroke downwards just until you reach the suprapatellar pouch and press downwards. With the other hand, perform the same movement and stop just below the apex of the patella. While applying downward pressure, take one finger and press onto the patella and see whether it's floating. If you can feel that the patella is floating when you're tapping onto it, this means that fluid has accumulated under it, and it is an indication for swelling in the knee joint. This was all. To conduct the brush stroke or bulge test, have your patient in supine lying position with a fully extended leg. Then begin by brushing proximally at the medial side of the knee with a relaxed hand and relaxed fingers. Consequently, brush down the lateral side of the knee, and you can observe a positive test if you can see a wave of fluid floating down the medial side of the knee. Okay, this was the patient lies in supine position with the knee joint slightly flexed and the ankle joint is held in 10 to 15 degrees of plantar flexion. Then grasp the patient's heel with the contralateral hand while the patient's foot lies on the anterior aspect of your forearm. With the other hand, fixate the patient's tibia as close as possible to the joint line and then draw the foot anteriorly. Alternatively, you can place the patient's foot on the table and use a plinth to put the patient's foot into 10 to 15 degrees of plantar flexion. Then fixate the foot's position, grasp the tibia with your other hand, and push the tibia posteriorly. In a positive test, you would feel increased anterior translation compared to the unaffected ankle and might be able to observe a dimple appearing on the anterolateral aspect of the talus. Miller et al. From 2006.
To do the test, have your patient sitting with his knee hanging off of the table. In order to test the anterior talofibular ligament, bring your patient's foot into plantar flexion so that the ATFL is perpendicular to the movement that you are going to perform. Then, grab the calcaneus and perform inversion. In order to test the calcaneus